Good morning, everyone, and welcome to today's COHTAC Share and Learn. We're excited to have you here. I had the pleasure of meeting many of you in 3D recently at our LHP convenings. And now we're back on our little Zoom squares, but it's good to see you all here. And thanks for joining us. So the bulk of today's presentation is going to be focused on strategies for effective oral health communication. I'm going to run through a few slides first before I hand it off. So as all of our webinars, this meeting is being recorded and we'll be posting it on our YouTube channel afterwards. And questions are welcome in that chat box that you should see at the bottom of your screens. And there will be a chance for you if you want to raise your hand later on and ask a question live, and you can unmute yourself and we can have a verbal dialogue. You're also welcome to put comments, resource sharing, and other anything else that you want to share in the chat box. And then at the end, we'll post a poll with some evaluation questions, and I have a Qualtrics link with a few short questions where you can type in some responses to tell us how things went today. Okay, so for today, like I said, most of today is going to be focused on talking about strategies for effective oral health communication. And we have Anthony Eleftherian here to run us through that presentation. And then the last 20 to 30 minutes, we're going to be coming back to some of the questions that you all submitted about collaborating with dental hygienists. And we have Jennifer Frisetta here, and Travis Trammell will be joining us a little bit later on to answer those questions. So without further ado, I am going to introduce Anthony and take my slides down so he can get set up. Okay.
Hello, everyone. Thanks for joining. Today, we're going to run through some basic concepts of oral health literacy and how to apply them to health communications. And let me just get into the right mode here. There we go. All right. Well, I'm Anthony Eleftherian. I'm Director of Communications at Health Research for Action at UC Berkeley. We're a health disparities center, conducting quite a lot of research into health disparities, but also outreach. And a lot of what we do is communications-based. We've been around for well over 20 years. Have developed a number of materials throughout California that are used by the state and elsewhere, and of course, throughout the U.S. Our focus is on communicating clearly and effectively with our intended audiences. And a lot of that is just, talking to them and figuring out what they need and what they want, and trying to communicate that as simply as possible, and making things as useful as possible. Okay. All right. So I just want to run through the objectives today. Already had them up for a moment. They've actually changed a bit. Having reviewed a lot of the pre-registration survey, it seemed like everybody was interested in a more basic presentation about oral health literacy and oral health communication. So we've given those before to this group. So we were trying to do something a little different, but it seems like that's really what everybody would like to focus on. So we've removed the social media element from presentation today. There wasn't a lot in it anyway. It was kind of a small portion of the presentation, and frankly, it could all be summed up in a sentence or two, which I'll reserve till later. But essentially, we're going to be going over the importance of health literacy and information design. The last is of particular importance because it kind of gets not as much attention as something like plain language, right? So people talk about plain language as essentially being synonymous with health literacy, but really it's the way in which we strategize to organize information that can make something either clear or not. And then just using that design to communicate health information effectively. All right. And just a brief overview, I'm going to be going over what is oral health literacy, which a lot of you probably already know, but it'd be good to review the different ideas and different concepts related to health literacy and its definitions. And the universal precautions approach, which some of you may be familiar with. And then, of course, using plain language, which again, we've gone over in the past, so we'll go over that briefly this time, but we did want to go over it once again. And then the bulk of today would be about strategizing for organizing information, and then just some of the resources that are available to you for oral health literacy and creating materials. All right. So as I was saying, the concept of health literacy has been around for about 30 years. And the most common definition concerns individuals. And that definition states that health literacy is a person's ability to find, understand, evaluate, and use health information. And that was the first conception of it and the original conception of it, and it's one that people probably tend to remember even now. But the definition of the idea of health literacy and oral health literacy has expanded greatly since this concept first emerged 30 years ago. And the difficulty is with defining it purely as a state that individuals have or don't have, is that it puts the onus on the individual, right? To be either health literate or not, and it means that there's nothing that can be done about it. So there are also, though, health literate professionals. And last time we discussed what it means to be a health literate professional. And really, it's just anyone who helps someone else understand their own health, right? And as we noted, a healthcare professional can be health literate simply by, in many ways, right? But for example, a dentist or dental hygienist can be health literate by evaluating their healthcare environment from a patient's perspective and presenting health information clearly and making it easy to understand and act on. And say a community health worker could be health literate by using everyday common language and techniques such as teach back, which reinforce ideas during a conversation or even inside of a written communication. But in general, health literate professionals aim to lower the barriers to understanding, reduce feelings of fear or shame, and use empathy while helping people consider and adopt health-promoting behaviors. And we'll get into a little bit about what those things mean. They seem a little bit like buzzwords or a bit touchy-feely, but in the end, it's much simpler than all of that. All right, so another component of health literacy is that of organizations. And then whether the work takes place in hospitals or public health departments, an organization can aim to be health literate by, again, providing shame-free and equal access to healthcare and health information. Important point there. And applying HL principles to every touch point where they interact with, the public. So this can include written communications and verbal communications. So, and in truth, there isn't a whole lot of difference between the two. I know, a lot of people here, have a focus primarily on verbal communications, and a lot of what we talk about today will be interchangeable. So things that apply to written communications often apply to verbal communications as well. Okay, so why is health literacy important? It's a topic that's been in the air for a few years. People talk about it as being important, but it's not always evident why it's important. In fact, even at first glance, it seems like maybe it's a secondary priority or should be a secondary priority of public health. After all, most public health departments aren't always resourced well enough to do what seems like their primary and most necessary work, right? So helping people get access to the care available to them, including, say, nutrition, right? But as you know, how you communicate greatly affects whether you can make the public aware of the resources available. That's to say that your health literacy and the health literacy of your organization is important. In fact, we know that literacy itself is the best predictor, single best predictor of a person's health status. And it correlates more closely than age, income, employment status, education level, racial or ethnic group, et cetera. And just to unpack that a little, because it may not be quite clear what that means, we can likely say that literacy is a proxy for understanding. And if that's true, it likely is, then our ability to help people understand is a vital tool. All right, moving to the next one here. All right, so in terms of real world effects, low health literacy has been consistently associated with poor health status, including, and other poor health outcomes, but also less engagement with health providers, more hospitalizations and high healthcare costs, and less use of preventative services. It's also been associated with higher mortality rates. It seems that limited or inadequate health literacy also appears to significantly affect groups who have experienced greater obstacles to care based on their age, income and education level, racial or ethnic group, gender, or other characteristics linked to discrimination or historically linked to discrimination. That can include, geographic location, culture, and language. As you can see, these are the same social determinants that drive other health disparities. And while the list of these can be a bit overwhelming, there's a lot we can do via verbal and written communication to improve the oral health literacy of our communities and help make sure individuals get the oral health care they need. So one significant disparity here in the US is between people whose preferred language is English and those whose preferred language is Spanish. Studies have shown that Spanish-speaking adults in the US have lower literacy levels in their preferred language and the lowest average health literacy scores across all racial and ethnic groups that were part of the study. And this, of course, is particularly significant in California, where we unfortunately don't come close to meeting the health information needs of Spanish-speaking communities, both in terms of language access and health literacy. So looking now at the other side, improved health literacy for individuals, professionals, and organizations leads to better outcomes, right? So for instance, for oral health patients, good oral health literacy correlates to lower rates of dental caries and periodontal disease, more use of preventative services, better participation in their own care, and increased likelihood that they get the care they need. In a way, we can sort of think of oral health literacy as a tool to help create more equity in health communication. And by removing at least some of the barriers to understanding and acting on health information, which stem from the social environments where people are born and live, we can help empower them to care for themselves. So ensuring that people get health information in the language they need should always be a priority, of course. However, it's important to note that if those materials are difficult to read and understand in the original language, they're likely to retain those qualities when they're translated. So health literacy is not just speaking plainly, as I was saying earlier, or writing at a lower grade level. It's also how the information is organized and presented, how it invites the reader or listener into the conversation, and how it helps them believe that the information in front of them is well within their understanding, and to keep engaging with that material. Right? Again, we're just trying to reduce the barriers to understanding, right? Whenever we're speaking with someone, whenever we're writing for a particular audience. And the more we can do that before a translation, the better. It's not to say that, to make your material culturally relevant or, fully ready for your audience. You may still want to do things like usability testing, for instance, right? Where you get something you made or maybe even words that you're thinking of using in a conversation and testing it with the audience, right? Seeing how it goes over, seeing if it's understood, etc. And then using that and revising based on the feedback you get. Right? So, however, health literacy materials are easier to translate, and they do help carry clarity through to the next version. So we've been discussing, factors that influence the health literacy and the groups most commonly affected by limited or low health literacy skills. But it's important to point out that one cannot tell someone's literacy level by looking at them. right? Indeed, someone might express themselves very well, appear to understand, etc., and still not completely comprehend their own health or the info they're presented with. In fact, most people read several grade levels lower than the last year of school they've completed. And those numbers, they don't only suggest that lots of people have limited health literacy skills, but that they in fact do, right? And that even among this group here, there those of us, who struggle with health information. It's just statistical fact that a lot of us do, right? Regardless of our careers too. Those of us, and there are plenty of people in health who also struggle with health information. So, and one of the things I think about when we think about health literacy is that, what people experience during the health situation can be significant, right? So they could feel fear, stress, anxiety, embarrassment, unfamiliar words, etc. So all of these things are barriers for them understanding, right? It's just another thing to deal with, another thing to move on from in order to gain understanding. So just to give you a sense of how it can affect anyone given the situation. All right. And that's why it's always best to take the universal precautions approach and treat everyone as if they have limited oral or low oral health literacy skills. And this helps reduce errors and ensures you're not leaving anyone out, right? Whether that's, again, written or verbal communications. So some organizations struggle with this idea, right? That we're treating everyone the same, that we're assuming everyone doesn't understand. And a lot of times the idea behind that is that we tend to think of only some groups as having literacy, and that the groups that don't will be upset that we're talking down, right? Or condescending, or assuming that they don't know, right? They'll be offended by plain language. But we would argue that for everyone to think about how many disabilities are actually invisible, and treating everyone as if they have limited health literacy skills can deal with a lot of those issues, right? So, yeah, and again, health literacy communication area. Sorry, I should have hit this button earlier. Again, we're trying to ensure that the needs of all community members are met. Moving on to plain language. Here, so those are sort of the conceptual ideas of oral health literacy, but to make ourselves more easily understood, there are some strategies that we can use to help us, right, and to help those we're trying to communicate with understand. And the big one, of course, is plain language, using plain language. And there are a few important points that we should make about using plain language, because the term itself can be deceptive, right? There's this common assumption that one should just know what it is, what is and isn't plain language, that it's sort of inherently obvious. But the truth is that it really isn't obvious what is plain language. Sorry. And so, we might assume, for instance, that monosyllabic words are always plain and understood, and polysyllabic words are, more complicated and not well understood. But there are times when this simply isn't true, right? So the word vial, V-I-A-L, is a lot more complicated for most people, or for many people, than just using small bottle, right? So that's 2 words as opposed to 1, but it's simpler, for example. So, and just to again reiterate the point, using plain language doesn't mean to write less precisely or dumb down. We still want to communicate all the important information, including all the technical terms. Right? So in practice, we can ensure we're using plain language by trying to, first and foremost, use simple, everyday words, right? A lot of times, if you look up health literacy or oral health literacy and try to figure out, some tactics for using it, you'll hear about grade level. And, most grade level tests or schema are pretty simple, easily gamed. And a lot of the first one was developed during World War II to test Army recruits. And it's very simple. So, and it doesn't always tell the whole picture. I would say that it often doesn't tell the whole picture, and that the better way to think of how to write or speak clearly for people who may have some literacy issues or issues understanding, period, is to use simple everyday words. So words that, aren't necessarily in the kind of professional lexicon, right? And that's something that happens a lot because we all work in health, so it's common language for us, a lot of the jargon. And that's the one thing we want to avoid, jargon and acronyms, right? And if we have to use that sort of stuff, we want to explain it, right? And the other big thing is to give context, right, to whatever it is we're communicating, right? To establish the topic and then explain, right? And sometimes it's difficult to do simply because we're starting from a place of a lot of knowledge and we're trying to convey a point farther down the road. But sometimes you need to, start earlier, so to speak. So one of the simplest tactics for doing that, for using plain language, is to write however you write, or write with a lower literacy group in mind or an audience in mind, and then going through again, substituting short, simple words. This time a teacher said there's no such thing as writing, as only rewriting, right? And this is evidence of that. You want to take whatever it is that you've written and seek the simpler ways to convey that. So you can see some of the words here, pretty common in healthcare, right? Geriatric, medication, examination, maybe febrile is not so common. But even something like regarding or approximately or determined or physician, all of those words are, difficult for many people. And substituting with simpler, shorter, everyday words will help your listener or your reader understand you. Again, want to replace or define complicated terms with simple language. And the other point is to use as many words as you need to make it clear. As we showed earlier with the vial example, even if something is longer overall, if it's easier to understand, it's better. Okay, so that was a really simple primer on using plain language. I want to get it to the bulk of what we're going to talk about today, and that's organizing information. So this is the third presentation we've given to LOHPs the past few years, and we haven't really discussed this topic much, and there's no particular reason for that. In fact, this could have been the first presentation. In my mind, organizing information is probably one of the first things that one ought to think about when one is trying to communicate clearly, especially with public health information and certainly with written communications. So it doesn't matter if you're talking with someone or writing a blog post, how you group information can greatly affect how easy or difficult something is to follow and understand. So as part of our discussion today, we'll talk about several strategies, including one that's called chunking, which is really just a practice of linking information together in smaller pieces. And we'll discuss using things like advanced organizers, which is a fancy word for headers. Even there, you see the jargon, literacy jargon, and others. But more generally, what we're going to talk about today is information design. And information design is the term for how you choose to organize and present content. It encompasses verbal and written communications. And one way to think about it is the process of choosing what comes first and which second and which third, etc. Which information comes first, second, and third. So for example, if you consider food recipes, right? And here I'm going to ask for a little bit of audience participation in the chat. Please write what you think is the first thing that one generally conveys about a recipe, either verbally or visually. And feel free to just ingredients. And I was going to say, is it step one of the instructions? Is it the ingredients? People are saying time, pictures. That's interesting. Name. That's a good point. And that is actually the answer in a way. Picture of the result. Well, certainly if you want someone to use the recipe, I would say the picture of the result is probably the best way to go about it. What was hang on a second. That's fine. Preparation time. These are some pretty creative responses. Thanks for all those. Appreciate it. So someone kind of got at it a little bit, and that's the title. Here it is. Title, the name of the dish, actually, is the first thing you should convey, right? What is it that we're talking about? And so, we don't start a conversation, for instance, about this by saying, "Hey, first you take some tomatoes and then you, etc." No, we say, "I have a great recipe for, etc." Right? Who am I making the dish for is also probably a good idea. But again, it's just that idea that um, that what we want to talk about, giving context, right? The big picture. What is this about? What are we talking about? Helping people into the conversation you're having, or in this case, it's a visual representation of a recipe, and this is a pretty decent layout here, I would say. Although how they spell pierogi, it's pretty unconventional. I've not seen it before. So again, just this idea that that what we're trying to do is simplify things, right? Think of it this way. A lot of what we're doing when we're communicating information that's not easy to grasp is lead people through. We don't want to push them through, right? We certainly don't want to push them 4 steps ahead. We want to lead them step by step through the information. The first thing in this case is the title. So again, very straightforward in a way. But not always, right? I'm not always aware of what's straightforward. So well thought out information design, shows or explains to the reader what the subject is right away. As we said, there are titles, headers, subheaders, introductory statements, such as I said before, I'd like to talk to you about how to get free free dental care, something like that, right? That's not true. Nonetheless, that initial statement is expressing to someone exactly what it is you want to convey. And one of the important things about that is that it makes for less work for the person at the other end, right? And I think that is another extremely important thing that we often don't think about, right? We're trying to communicate to an audience. And if you look at it, we're sort of on the spectrum, right? Here's you here, and here's the person you're communicating with. But as the person communicating, you get to choose how much work this person does, right? Do they have to come all the way to you to understand you, or do you get to go all the way to them? And health literacy is the practice of getting as close to them as you can with communication, right? It's that simple. So again, they don't need to, search a document or wait for the end of a long monologue. They can hear or see what the subject is right away. You're making it clear. And because of that, it's easier to understand and use. And, moreover, they don't really need to feel that they'll stumble on some point or other, right? So people who have a history of not understanding communication very well, tend to assume that they're not going to understand. And there's a stress there. There's a resistance to grasping. There's a desire to flee in a way, both with a piece of paper or someone in front of them when it concerns their health. And we want to undo that. We want to invite people in. We want to make them feel as if they can actually get through it. And when you communicate clearly and in a friendly way, it encourages people to continue, right? That it encourages them to believe that they can continue, right? So I want to stress that last point. So it is very, very important. So again, ease of use. Sorry, I'm neglecting my button clicking duties here. All right. So to give you a sense of what we mean about information design, I want you to consider this graphic of a granitic block of text or granitic paragraph. For most readers, right, and this is just a visual thing at the moment, especially those with limited health literacy skills, it's simply discouraging to see this, right? In fact, at HRA, we test a lot of materials with people with low and limited literacy. In our experience, we find that many people just won't engage with text that looks like this. They'll scan it, maybe, and tell you they've read it. You could be sitting 2 feet from them and you know they haven't read it, and they'll still tell you they read it because there's a lot of things. There's shame, there's embarrassment, there's a resistance, all the things I mentioned earlier. So, if a text looks or sounds like this, that may happen. And if this were a conversation, you could think of it as, sort of endless stream of words coming from one person while the other one blinks, right? Waiting to leave in effect. So it's much better to organize the text, think about what we're going to say as best we can with clear sections, clear ideas, and convey the information simply and some degree slowly. So you might want to say something like, I want to talk to you about keeping your child's teeth and mouth healthy. Right? That's a really simple introduction to a conversation that you may be having, in the community or a community center, something like that. Or something like, or I have 3 things to tell you today. First, I want you to know that your child can get a free oral health examination at school. Next, if you want, we can help you find a dentist. Third, blah, et cetera, et cetera, et cetera. Right? So again, dentist test is discouraging, and people with limited HL just may not engage at all. So what we want to do is design for scanning. Right? We want to do something closer to this, something more inviting. It's easier to scan, right? And inclusive. And, in terms of a conversation, we'll talk about how we might do that and have on a little bit, but we'll talk about it more later. But essentially, we want to design the information, whether it's on the page or, for speech, so people can understand it quickly and at first glance, right? We have a saying at HRA where it's like, make something so people can understand it the first time they hear it or read it, right? They don't need to reread it. They don't need to bang their head on the table, vis-a-vis IKEA instructions, right? They want really simple, clear things to get right away. So, okay, I know this seems like incredibly obvious, right? Put important information first. It's equivalent to saying start at the beginning, right? But the truth is that it's not always easy to start at the beginning or put the important information first. And at virtually every level of communication, figuring out what comes first can greatly improve clarity and understanding, as the recipe thing earlier. And this is in part because context helps people understand, right? But it's also because the first part of a sentence or paragraph tends to make the strongest impression and is most likely to be remembered. So use the spot for your key message or behavioral advice, and think about it as what you want your reader or listener most to take away from your conversation or your text. Right? So put your key messages where they'll make the strongest impression. Okay, just looking at an example here as a simple sentence, right? It does, the thing's blocking, I can't see it. It does most of what we needed to do by putting the key information first, right? You can help you lower your blood pressure by lowering your salt intake to less than a teaspoon a day. Sorry. Right, so it puts key message first, right? It's, however, there are better ways to organize this in general, right? One thing we could do that would go a long way is break it up into 2 sentences, right? But essentially, looking at, we have a few things of information to convey. What are some good ways to do it? One of the key things, again, putting the key information first and worrying about the rest later. And chances are you'll look at something more than once and get a chance to split into 2 sentences, to make revisions, etc. And it's also another point here, the reason why we haven't, revised this all the way through to make it, really, really simple for people. And that's, you don't need to make everything perfect, right? Any win is a win in terms of how you communicate. So if you can simplify something just a little bit, right? Just get a little bit closer on that spectrum that I was talking about earlier, then you'll have done a pretty decent job at communicating clearly, right? Nothing is perfect, and you're not going to do it perfectly. But if you can make it a little better each time, by the end, you may have a really excellent piece of communication. So again, a lot to unpack here. It's a little complicated. Might want to put it in a second sentence. Okay. So advanced organizers. Again, sometimes the most important information is the topic itself, right? and what we want to discuss. And one communication practice that helps us do that is an advanced organizer. And an advanced organizer is just simply a way help the person on the other end understand subject and what information may be coming next, right? It's a way to organize information they're receiving in advance, right? So it's a concept used in adult learning, youth education, and it helps establish hierarchy of information. But it also allows readers to scan the subject of forthcoming information, as I said. And it does this visually by way of headers, subheaders, and verbally by way of introductory sentences. From earlier when I said, the I'd like to talk to you about, etc. It can apply to a first sentence, it can apply to a paragraph, or the header of a section. Okay. So just here looking at an example, this is HRA's California Parent Guide, which some of you may be familiar with. This is the left page, so the new chapter in the guide. And, just based on some of the things we've discussed so far, I was wondering if in the chat anyone could tell me some of what this is doing well. It's all pretty simple. Yeah, using an image for sure, that helps. It breaks up the text, it allows people to think there's not as much text to read, they can get through it, for sure. Introduces the main topic of viruses right. Absolutely. Pictures related, there are headings, QR code for more info, headings, highlights key info, QR code. Yeah, all of those things for sure. I have to move this. Larger print, yeah, that's for sure. That helps. And language is easy to understand, yeah. But in terms of organizing information, again, the top level header indicates what the page is about. In this case, it's actually a whole spread. So you just don't have it all here. But about viruses, right? Literally about viruses. So it's as simple as could be. It's 2 words, and it conveys the topic. And then also the subheads, right? Another good simple definition of viruses, that's true as well, right? So the subheads indicate what each section is about, right? So someone could scan this. When I said scan for information earlier, that's what I meant, right? I can look at the top headlines and know what this is about, not just viruses, but also, what viruses are not serious, what viruses are serious, and then COVID-19, right? So, and again, in some cases, I want to point out that the first sentence also signals to the reader what content is up ahead, right? So here in this introduction, and that's something that's important as well, there's a title, and then there's an introduction to the topic, right? And then the actual subtopics. Right. I think I better speed up a little bit. So another thing to consider and avoid when trying to communicate clearly is the embedding of information. An embedded clause, I'm sure everyone knows, is one that interrupts another clause. And you can think of it as parenthetical statements. And they aren't desirable and easy to understand content, of course, because they force people to remember the first part of a sentence after they've read through the parenthetical statement and then get to the end, right? So some readers can easily forget where they are or where you started, and it's better just to use another more straightforward combining tactic or make 2 related thoughts into 2 sentences. Right? Again, it's very unfriendly. So, another reason why this is important, the reason why we mentioned this, right, in terms of organizing information. Okay, you may notice we're kind of talking about like sentences, and then we'll talk about paragraphs, etc. So, whenever we, so the thing about it is this, right? So when we embed information, or just in general, when we're trying to write complicated sentences, or when we do, the truth is a lot of us academically, historically, have been commended for that, right? It's something that gets commended, to write labyrinthine, complicated sentences makes us seem smarter to other people. Those people think it's smarter. Our teachers give us feedback that it's great, and that But of course, the assumption there is that to write simply and clearly is less intelligent, or less sophisticated. In truth, as I'm sure many know who've ever tried to write anything, the opposite is true, right? To write simply is much harder than to write crazy complicated sentences. So another thing to keep in mind when you're writing for an audience who struggle with health information. All right, so a quick example of what embedded information looks like here. I need to move this. Sorry, I can't read the whole thing. So again, it's very important to take your pills, whether at dawn, noon, or night, correctly. And you can see whether at dawn, noon, or night interrupts the actual statement, right? And it interrupts the flow. And it makes it easy to lose track of what the information is about. So one way of dealing with it is to simply put that embedded information at the end of the sentence. Right? So here we have it's very important to take your pills correctly, and then whether you take them at dawn, noon, or night. We can argue about how good that sentence is overall, but this is a way to make it a little better. Right? Put the embedded info at the beginning or the end. Another way to look at it is to put the embedded info in a separate sentence. Right? As you can see here, we've done 3 sentences. And yet another is to delete the info if necessary. Right? Is that information really so important right now? Or is the most important thing simply to convey that it's important to take your pills correctly? And then we could explain somewhere else how to do that without saying whether at dawn, noon, or night, right? That's really extraneous information. And we're tempted to do that very often, right? But looking at things and trying to find what's important about them and make them front and center. The way to approach not embedded or avoiding embedding information. And there's another reason why kind of long, complicated sentences or poorly organized sentences and paragraphs are difficult to understand. And it's that most people can only keep 3 to 5 items in their working or short-term memory at a time. And of course, if they're stressed, older, don't understand all the words, or generally process information differently, then it can be even fewer. So thus, communicating all but the most basic idea may even be ill-advisable at times, right? So yeah, when it comes to health literacy, when it comes to health communication, really the best general advice when you're thinking of what to say or what to write, is to follow the instruction that most of us received in middle school, and that's one idea at a time. Which brings us to creating paragraphs, where that idea of only one idea is as helpful as it is anywhere. And that's whether it's written or spoken, right? So on some level, organizing information is really just about shaping a paragraph, right? We're trying to link ideas that are related, and make sure that the topic is easy to follow. So some tips for doing that, in addition to those that you all no doubt already know about paragraphs, such as creating topic sentences and that sort of thing. Here are a few simple things to consider when you're trying to organize what you're going to say or write to someone with limited health literacy skills. It's simply when you want them to comprehend as much as possible, right? So you could start a new paragraph, right? Essentially, when you introduce a new idea. When you want the reader or listener to digest the information you've already conveyed. So for oral communication, verbal communication, this can be simply a pause, right? And it's also a good time to use teach back, which we talked about last time, and it's simply a technique that reinforces that you're understood, and you can read about it in the oral health literacy toolkit. And you can also start a new paragraph when the material becomes too difficult or long, and breaking it up will be reader. So this kind of goes against some things that a lot of us are taught to, where we try to keep all related information together. But really, if we can give people the feeling that they're accomplishing something and breaking that little mini rule by making shorter paragraphs. I mean, talking about like two sentence paragraphs, totally fine. So long as it helps people understand, it's for the better. So, all right. So yet another way to think about paragraphs is a concept in health literacy called chunking. And this is when we break information into small, manageable bits, as we just described. And chunking helps comprehension because it gives reader less to remember, reader or listener, less to remember. It's overall gives the reader time to process the information you've said or written as well. And it gives them the confidence to learn, right? And just in general, all of these, as we said earlier, sort of encourage the listener to say yes to engaging with the information, right? Because that's the hard part, getting people to listen or to read or to follow along when they don't want to, right? I mean, most of them, in a lot of cases, they simply don't want to, and you have to convince them that they can, right, or that they should. So you want to increase that likelihood that they'll ask questions and listen and continue reading. And these things will help. All right. So how do we chunk information? Again, kind of, one good rule of thumb is simply following that short-term memory concept, right? And to keep it to 3 to 5 sentences per paragraph or section. Obviously, with verbal communication, it's fewer than that. Another concern is, the scope of the paragraph. You want to try to keep, as we said earlier, one main idea per paragraph or section, one main idea that you're talking about at a time, right? Try not to leap from one idea to another in the middle of a conversation. And keep that information essential as well. Another, visually, is to try not to write more than 100 words per section, right? So we want to create a sense of white space on the page and let people feel like they don't have to read or look at the dense block of text, that they won't, lose track of where they're reading. Because if you think about it, reading is, it's a physical activity, right? And your eyes are trained to do it well or not, and that happens over time. So if they're not trained to do it well, it's easy to see that and know that you'll get lost in a paragraph, or it's easy to simply get lost in the paragraph, right? So keeping the paragraph or section shorter helps people get to the end without stumbling. And if you can create that kind of, pardon me, seamless experience for people as they're reading or as you're speaking, again, it's more likely they'll continue. Okay, just looking at this example again, I wanted to look at how the sections and paragraphs, again, just discuss one topic, right? What viruses are not very serious, what viruses are very serious, and they don't veer from that topic. And again, the paragraphs and the sentences are very short, right? 1 or 2 sentences, and the sentences themselves are maybe 8 to 9 words, 10 words tops, and that matters. They're clear, active sentences, of course, with simple words, but in terms of their organization, there's not a ton going on here. People can digest this easily because it's been well chunky. And just some other examples of that. It's kind of an very old piece about CalMedi Connect, which was a pilot program, some of you may remember. And again, just really simple sentences in the paragraphs, not very complicated. And in some cases, another strategy for organizing information is to create lists, which is does here. All right, and here's something even simpler. We developed this with a partner, a healthcare organization, and we were trying to get them to switch from a text-heavy concept here to a more of a visual one, right? So there's very little text on this page, and there's an opposing page with another image and I think even less text. But as you can see here, very simple, very straightforward, visual representation. But mostly what it does is break it up into small bits and let people feel like they can get through it. All right, I'm gonna check on time. I think we're gonna skip the chunking exercise. because we don't really gonna run out of time. So so what are the, some of in partnership with the Office of Oral Health, we developed an oral health literacy toolkit, and it was mostly designed for healthcare providers and to help them learn the basic principles of OHL, including communicating clearly and with cultural humility, and creating in general a shame-free and fear-free dental environment. However, so we know that the toolkit in general is probably of limited value to local oral health programs. But there are two resources that could be helpful to your program. We did want to mention them again. One is a teach back booklet. I mentioned it earlier. So this contains, step-by-step an explanation of the teach back method. We discussed it at our last presentation, and you should be able to go listen to that if you want to, but you can just really download the booklet and get the gist really easily. It's very, very straightforward. Gives you, again, step-by-step directions. It also it gives you some opening lines for teachback, so some prompts basically for using teachback. And there are some scenarios and scripts, but they're all kind of oral healthcare focused, so they may not be of as much use. But really, the first few pages can give you the gist, and the rest is just practicing, right? It's just getting in the habit of during a conversation, asking someone to repeat it back to you, right? Very, very straightforward tool that could be of some use if you're out in the field and speaking with people regularly. And that is also available in Spanish. So it gives you instructions in Spanish, prompts in Spanish, etc. Just if you're communicating mostly in Spanish language, it'll be useful to have it translated in the terms that make sense and that have been tested with audiences. So that's the other part of this, is that we did test a lot of the language with people who have limited literacy skills to make sure that it's easy to understand and culturally relevant and all that. I believe we've also translated this recently into simplified Chinese, but it's not available just yet. Okay, and then there's a patient resource. Some of you may be familiar. This is also very, very basic. Obviously, you'd have to print it. It's kind of a brochure. Not kind of, it is. It's a 6-panel foldable brochure. Very straightforward. It essentially explains, it's called Going to the Dentist. And it was developed for community members who have limited or no experience going to the dentist. So for instance, recent arrivals here in the US or in California and from other countries. And essentially it explains the before, during, and after of dental visits. And explains, what to expect, how to prepare for a dental visit, etc. It's very straightforward, easy to read, not a lot of text. It's so basic that when we were advocating for it, people were fighting us because they felt it was too basic. But we felt this was needed in the state as a useful tool for lots of individuals, and then also for community health workers. And it too is available in Spanish. Sorry, this screenshot's a little out of focus here, so it looks better in actual reality. So, all right. So if you want to access the toolkit, here is a QR code. You can, I'm sure a lot of you are familiar, you can just go to the COHTAC site and see it there. And you can download the individual resources. It's pretty straightforward, whatever you'd like to do there. But we're happy to follow up with a link as well after the presentation, after the meeting today. And then likewise, we wanted to, for those of you who aren't aware, I understand that more and more local oral health programs are also using the California Parent Guide, California Parent Kit. The kit is produced by First Five. HRA does makes that little California Parent Guide. It's an 86-page resource, but there's lots of oral health information in the kit in general. Including advice for pregnant people, nutrition information, again, oral health advice for all ages. You can make bulk orders. You can, with this QR code here, you can order an individual kit just to see what it looks like if you're not familiar with it. This bulk order process may have changed. They've had some changes at First Five, so maybe simpler now than that. But so if you're interested in a bulk order or just this particular flyer, we can we can get that over to you. But again, this is a pretty useful piece for people, young parents or new parents. Lots of information, especially in Orlando. All right, well, that is our very quick summary of strategizing it, how to strategize to organize information. There's a lot more to discuss about those things, of course, and we'd be happy to chat about them with anyone. If you feel, I should say, feel free to reach out to me here at this address if you have any questions about information design in general or specifically. If you're just looking for general advice about getting started with creating communications. I know the state doesn't always make it easy for the local health programs to create their own materials. I know the review process can be lengthy and arduous. So we're happy to have a quick chat with anyone who's interested. You can contact me or anyone else at HRA, and we can set up a meeting and just discuss, some of the issues you may be having, or just figuring out how to get started, or point you to other resources if you're having a particular issue. So, thank you for listening, and if you have any questions, feel free to speak up or write them in the chat.
Excellent. Thank you, Anthony. Are there any questions from anyone in our audience?
Hello, this is Claudia at the City of Pasadena. I really enjoyed this presentation because we currently do similar work like this, but this just makes it even more of a refresher of like, okay, maybe I can modify this and modify that. So it was really good. We're working with another team member with our clinical staff, and we let them know all the time that we need to modify a lot of the language, and their reasoning on why they don't want to sometimes is because it's empowering the client to know these words. And I let them know, like, I understand, but the slide doesn't have to be busy. Like, we can explain it ourselves as well and show them the keywords and empower them in that sense. But like the readability and access to the information just needs to be more community centered. So I wanted to see, like, how could I support clinical staff, but also really encourage community readability, essentially.
Yeah. Well, it's really tough. I mean, you could show them the stats about what people understand. I mean, and you're talking about, the last study to look at health literacy in the U.S., 2/3 of U.S. adults struggled with health information. It's like 90 million people. And again, that means lots of us here, not just people out there who don't work in health. It's everybody. And but for me, even that's kind of abstract, in a way. But to tell people that most people read 2 or 3 grade levels lower than the last year of school they've completed opens some eyes, I think, generally, just because you're not expecting that, right? You're expecting to be able to read past where you went to school in most cases, right? And most people can't, because especially now, right, with most of us like living full time online, it's the ability to process information probably dwindling. So in terms of communicating that, it really depends on the individual you're talking to, right? You can what's gonna move them. We struggle with the same thing on our team because we work with academic researchers, and if you think clinicians crowd slides, I'd like to introduce you to some UC Berkeley researchers who have never just don't like white space on a slide at all, and just because the impulse again is to convey everything, right? But I think more than conveying everything or using complicated words, it's this impulse, and I think it's pervasive in public health, is to have everything, do everything all at once, and it doesn't need to. Whatever your objective is, just stick to that and convey that, and that'll be enough, right? It's like trying to give people, the contents of a textbook and 4 slides or something. It's not going to do anything. In fact, it does the opposite. People won't learn or know or understand much of what you're saying. So again, just try. I mean, I just think simpler is always better. And start. And just, I mean, maybe if you talk about it as a way to, it's a way to start the conversation. They're not going to process information from a slide or go through that conversation, and just to start the conversation, to start the idea that this is a subject that they need to know about, et cetera, and they can learn about more, and just maybe modularizing your content in that way, so maybe you've convinced them to, what if we did more more presentations, they're just smaller, or less topic heavy or whatever. So that might be an approach as well, but yeah, it's tough. I don't, because again, if you're clinicians, academics, as I said, with all of us, we've all been commended for making things complicated and seem complicated and labyrinthine. So you've been getting that pat on the back your whole life, and it's reinforcing. It's hard to break those habits.
Thank you so much.
Yes. Hi, Magali. Sorry if I mispronounced your last name.
Oh, you're fine. Hi, I'm Magali with the Alameda County. Thank you for the presentation. I was thinking that part of the audience that we work with are organizational staff and community health workers, family visitors, home visitors. So I sometimes, what's your opinion of including in a presentation training for them some pictures that shows that they can differentiate between a picture of healthy mouth and also gum inflammation or something that's not healthy? Sometimes is it disturbing to show those pictures, or is this okay?
So the research says for sure people don't want to see them. I mean, it absolutely, it turns people off. I remember I had this argument with people at the ADA once because they were asking us to review their materials, and their materials are super graphic. They're like, they really put it in everybody's face, and I think more than anything, I mean, sure, we want people to be able to recognize what could be a problem, right? But there's a fine line there, because right away, and especially with oral health, there's such a shame contingent involved for so many people, because they don't go to the dentist enough, because maybe they don't take care of their teeth or mouth the way they should, or the way they feel they should, who knows. But a lot of people have tons of shame across, all the normal factors or characteristics of the public. And so you can go, if you're really confrontational with an image, maybe that just makes people back away and not deal with it, right? So, I mean, we at HRA always try to avoid that approach, just because it's not inviting. It doesn't often go anywhere. Like, maybe you can have that conversation in person. You can, when people are engaged already. But if you're just trying to show them something to get them thinking about, coming in for an examination or something, it's probably not the best way. But I think it depends mostly on context. But for sure, I would be hesitant to do it.
Thank you.
Thanks for bringing up that very important topic. I appreciate it.
Thank you.
Thanks, everyone. I think we're going to transition now to the second part of our webinar. But if you have other questions for Anthony, please put them in the chat box. I think he'll be sticking around for a bit. So if you have anything that you want him to answer, put them in there. I am going to now transition to answering some of the questions that were submitted for dental hygienists around collaborating with LOHPs in schools. And so to answer these questions, I'd like to invite Jennifer Frisetta and Travis Trammell to unmute and turn their cameras on while I introduce you. So Jennifer is a registered dental hygienist and the San Benito LOHP program manager. She's worked in both the private and public sectors and is committed to improving oral health for everyone in San Benito County. Travis is a registered dental hygienist in alternative practice, or an RDHAP, and is the founder and owner of the Jerry Smiles Mobile Dental Hygiene Practice, a Riverside-based mobile practice that brings dental professionals into schools, health fairs, homeless shelters, and churches. He also recently earned his PhD in clinical Christian counseling, so he's now Dr. Travis Trammell. I'm going to put in the chat the bios of all of our speakers for today, so you can read more about them there. But now I think we're gonna go ahead and get started. And I should say that these questions came from the Share and Learn that we had to cancel in March. And we are still working on getting all of your questions answered. There were a lot of them, and a lot of them require a lot more review before we can post the answers. But we did get some responses from the Department of Healthcare Services in Smile, California. And they are posted at the link in the chat there, so you can access the questions that you wrote in for them at those links. Okay, so I'm going to go ahead and move forward, and we're just going to go question by question and ask both Jennifer and Dr. Trammell to answer the questions. So the first one that you raised was, how do you help motivate districts or schools to implement oral health programs? And how do you motivate schools, classes, and parents to sign the necessary consent forms for services? So I'm going to ask Jennifer if you can answer this one first, and then we'll pass it over to Dr. Trammell.
Okay, so I don't do consent forms anymore. I use passive consent, but in the beginning, I was working with the regular consent. And I think that if you're having trouble getting this, I would definitely go to the top and motivate and down. So in other words, go to the superintendent, make sure that they understand, then maybe go to your principals, go to your school nurses, go to your teachers. And I've had really good response back, because at least when you start talking about the importance of missing school and getting lower grades, and I always bring some research with me to share. There's one thing that is going to click with everyone, and that's not necessarily the same thing. So I bring a variety of messaging with me, and to see which one I can see they're interested in. And when I understand which one is really speaking to them, I go with it. For example, I had a superintendent one time when I said, did you realize that poor oral health is severely affecting our children and their grades? And he said, can you back that up? And I said, I sure can. And I happened to have 3 different research articles on it with me. The minute I showed him those, everything changed. He was more interested and helped me along the way. And same thing when I went with one gal, and I know that our former speaker, who was wonderful, by the way, he said he doesn't use pictures. I do use pictures. I don't use as many graphic pictures as the ADA does, but I will always preface it by saying, let me show you what you can do to help and who we can identify. Can I share a picture with you of someone here in San Benito County, especially at the age of 5? And when I do share those pictures with people who agree to it, that's usually all I have to do. So not to take too much time, but I'll go ahead and let Travis speak.
Actually, yes, thank you there. This is actually a 2-part question, because usually if you're motivating schools in the oral health program, usually I'm talking about the kindergarten oral assessment program. But then when you talk about consent forms, that's my second model, which we use is the sealant-based or full service programs. So as far as the kindergarten oral assessments, the only thing that we're trying to do now is trying to figure out now the implementation of how many kids are missing school because of oral health. You know, what do our little kids look like in kindergarten? You know, most of the teachers don't look in their mouth. You know, they leave that for the parents to see. And so by motivating them, I'm always the same way. Like Jennifer's like, we got to show pictures, because that's not something, especially during COVID, everybody had the mask on. Everything was hidden. So my approach is I don't do superintendents, I do the board. Going to the school board meetings, and they'll give you 5 minutes to do a presentation, 5 to 10 minutes to do a presentation. And now you hit the hearts of the board, the officers, and the family members all at once. And you're only there to help, because every school district no matter where they are, they're all fighting the same thing. It's classroom absenteeism, and everybody's trying to find programs to reach that and to update, because if they don't get that classroom attendance up, they lose funds. They lose funds, they lose teachers, right? And nobody wants to lose their job. So motivating them is just, how do we put money back into your pocket?
Right.
And this program can put money back into the pocket to basically maintain your school, the educational process. And then the last portion of this is, how do we motivate the schools, the classes, and the parents to sign this? I do competition. Because I'm a private entity, I could do what I need to do in order to motivate. So I do pizza parties for the first 2 classes that get me 100% participation. And that really beats, I didn't know a slice of pizza was just that much of a incentive. They love pizza, and they get pizza chips, and, I give them an organic juice, to keep that healthy drink going as well. So those are some of the things that I do.
Well, thank you guys so much. Let's move on. Okay, so if an in-school provider identifies an urgent case during a school screening and the school nurse is unable to follow up, what's a reasonable expectation and standard protocol for the provider to follow up if they don't have access to the children's information? Dr. Trammell, do you want to start with that?
Got it. So what I've done with school districts is up to the school nurse, because they actually have the information. And it's another 2-part questioning as well, because you got the kindergarten oral assessment. We don't get any of the school data or the children's data. Only when we do our Jerry Smiles dental consent form do I have that information and can follow up. So usually from the first stage, we give a list of the urgent to the actual nurse, and then they have those there. They can pull the data and they can share it back and forth if they need to. But most of my schools have not had that problem as far as following up. But I give them 7 days. Why do I give them 7 days? 7 days is that perfect number. And it's just 7 standard days that they have time to give them a call, find out if they've gotten an appointment, because we are mandated reporters at this point. Depending if it's an urgent, that means this kid is in pain. There's things going on that needs to be followed up with, and we don't hold that lightly. But if the county wants to work with them as well, then just make sure all the MOUs have a contingency with all 3 parties, the school, the county, and that provider linked together to be able to share that data and to make that actual follow-up protocol, and to make it that much more effective.
Thanks, Jennifer.
And I have, the process is a little bit different here because we're a smaller county. I am the one who is identifying the urgent cases. Our nurses have told me that they are not the expert in this and they want me to handle it. So what I do is I make a copy when I identify those who are urgent. I give that identified urgent need of care to the nurses. They then give me the information for the parent contact, and the school itself will tell the parent that I will be making contact. And whether it's me or a school liaison, we call and we say, do you need help getting a provider? And once we do that, if they say yes or no, we'll do a little bit more follow-up. And then normally between 1 and 2 months, because we don't have enough providers here, I do a follow-up to make sure that the child has received the care. For example, yesterday I went in and there was still a child that did not have a provider. So we did some follow-up there. So our process is a little different, and our nurses have said that they do not have time to do any of this and they don't want to. So they really put that back. And I think that the LOHP can be a really great mediator between the provider and the school nurse. So we really have to work together.
Right, this is a broad question, but what are the best ways that LHPs can support the work that you do in districts or in schools and in your efforts to expand the work that you do? Dr. Trammell, go ahead.
I was like, who's going first? The best is, working with Riverside County, San Bernardino County. I can only brag on those 2 because those are the 2 that I started out with. And the work we've done in those 2 counties has been amazing. They set the stage for us as far as their local oral health meetings that they do with the community partners, and putting us out front with the school districts and with the other agencies, and setting that stage for what we do and why we do it. But I think, like you said, it's everybody working together for the same common goal. Even there are few providers. Hey, we put those few providers on pedestals because if we don't have a lot, let's let them know how much we appreciate the work that they are doing. And as far as we expand, two other counties on here, Shasta, San Mateo, that have reached out as well and wanting to do some expansions. Because you'll understand from me, I don't like a lot of red tape. I don't. That's why we're private, right? So we can do what we need to do to cut through the chase and to get what we need done, which is getting the data and getting these kids served. So districts that are setting their partners up, having the local area health meetings with all the strategic partners and making sure everybody is being held to the same standard is amazing. But having those partners, you can't speak much more of that. And getting the school districts involved, and it has a lot of weight when it comes from the county oral health department. You know, we're not here to, you know, put a microscope down the school district or anything like that. We're just here to provide services and to make sure that classroom attendance and all those things are actually benefiting each other.
So it's a little bit different because I am the LOHP and I am the one doing all the assessments. So I think, again, just like Dr. Travis said, we all have to work together. I think that I support the schools in a way where schools talk. So if you get something that's working really well, the schools will, principals, I know the principal I have my brushing programs on, I get calls weekly now. Hey, we heard about this school. We'd like to do that too. And so, and showing the data from that school. Sometimes schools are charter school is really competitive with our public school. And they saw the data from there and they called me in and really wanted to have some type of a competition between them. Classrooms. It's really nice to support different classrooms and different schools, show them the data and show them how they can, the things they can do to reduce the decay rates. And I think that we support the classrooms, we give them tools to use, and then the classrooms instead can give a report back to the teachers at the parent programs, at the board meetings as well. I was just at a board meeting with the teachers and the parents. And I think that we all need to share the information, just like Dr. Travis says, and show them what's going on, show them the success, and give them tools that we can help each other. And I think that it works really well. And by doing that, it's actually expanded. I know the board just asked me if I could do every single class, which of course I can't do. But once you get something that really works well, it seems like the school district themselves kind of take on their own and start wanting more.
Thank you. I mean, you guys are getting some questions in the chat, and at the end, I'll try to get back to them. But we're going to keep going with the questions that were submitted. Okay, and this actually goes to some of the points that are being raised in the chat. So there are a lot of questions about how you contract with schools or LOHPs and how you bill for your services. So let's run through some of those. So if the hygienists are employed by an LOHP, how can they be paid through Prop 56 funds for allowable services and activities, but also bill insurance directly for services delivered at schools? Jennifer, can you take this one?
Yeah, so I was my first 5 years, I was contracted with our county, and I was paid through Prop 56 funds. So every county is, I believe, a little bit different. I made up our actual, we did not have a position here for a public health dental hygienist. So I was very fortunate to create one and to put in a little bit more of my scope of work. And in my scope of work, I put allowable services and activities. So what I would do when I was a contractor was I would bill the county and I would put the services, for example, assessing kindergarten oral health assessments. I would just bill that as a regular public health dental hygienist, and then the county would pay me, and then they would bill the state. And I did not separately bill for services through any other Medi-Cal or anything. So I only did billing through the county. And as for sealants, at that point, we just did a link to a dentist to do the sealants. unfortunately, here in my county, probably 98% of the people that I work with do not even know what sealants are. So that's been a struggle.
Do the insurance reimbursements for service provided at schools fully cover all of your salary and your staff salary for costs for doing the screenings? And if not, what other funding sources cover your other costs?
That's what I was understanding. Do the insurance reimbursements for services provided to schools fully cover your salary and the cost for doing screenings? That's another twofold question, because screenings is only a separate, I keep that separate from COA. And then actually insurance billing I do for services only. So back to the same question we just asked. COA is I bill the LOHPs for that. And then we take whatever your total dollar amount and we divide that by how many screenings can I do in that. And that does cover the salaries for those hygienists that are going out doing the screenings only. And then, like I said, the insurance reimbursement, the Medi-Cal side, we try to make that cover the salaries, but it doesn't fully cover those salaries. I also get grant fundings from DPSS, other county funds, and other programs that are going on as well.
Okay, so more questions about who actually handles the billing. So if a hygienist is hired by an LOHP, who handles the claims and reimbursement paperwork? Is it the responsibility of the hygienist or the LOHPs? Jennifer?
So all the billing is done by myself, and I just get reimbursed by the county again. I do not do anything with Medi-Cal, and in a way it works to my favor here in my county, because when they hear the word free, everybody wants to do it. Prior to me coming on in 2018, they had FQHC doing it, and that did not take off well. So by the time I came in 2018 and I said that this is part of my program for the state, went over fine. So I just bill for my services.
And Dr. Trammell?
Well, I'm contracted by the LOHP, so I'm not actually hired, unless you're looking at hire versus contract. That's another thing too. So then you got to look at, is it an employee of the county or they are contracted by the county? So there's a lot of differences there. But as far as claims and reimbursement, I would leave that to the provider only, unless the county is actually billing Medi-Cal, depending on their program. So that's a lot going on in that question there. But as a responsibility, like I said, kindergarten assessments is not paid by Medi-Cal whatsoever. It's a zero cost. So that's why that cost only goes to the LOHP, the county, for the reimbursement of that. But as far as if a hygienist was doing cleanings, fluoride, sealants, then I will leave it on that hygienist to actually do that paperwork, because there's a lot that goes into that as well, and making sure you do get the Medi-Cal number, you know, from the kids, and that's been a struggle as well. Or trying to work with Medi-Cal and the parent to get that service done, because getting those numbers, I don't know why, but the parents feel that their Medi-Cal number is like their social security number, and they don't want to give it up. But for most of them, they do, once you're actually breaking down those barriers and helping them to make sure they don't have to take their 4 or 5 kids to the dental office and sit there for 2.5 hours, 3 hours, and vice versa, that you're actually bringing the service to the school and helping the parents break down some of those barriers and making sure they're not for the school. You're keeping those kids in school based on the services that you're providing.
Your point about subcontracting with an LHP versus being an employee of the county. So can you speak to some of the pros and cons of the different ways that you can work with LOHPs? Maybe Jennifer, you can start.
So, you know, when I was a contractor, I'm a regular employee now. There's pluses and minuses to both. It's kind of nice when I was a contractor, I could make my own schedule, although I didn't just focus on the KOH A's. I did the whole scope of work. I did it at my leisure. So when I had time, I would work on that. I also had was contracting with Anthem Blue Cross at that time too. So it was nice to have your own schedule. It was nice to go in and maybe do a week of the kindergarten oral health assessments and then work on some of the other stuff. I was also doing the needs assessment. And then it's a little bit different when you're a regular employee. I don't have that time that I had before. I'm more in a crunch. I have to do those progress reports, you know, and get those done with all that. And it just, so it just depends. Although now, when I was a contractor, I didn't get insurance and all that, but I do now. So it really, I think it really depends on your personal situation. There were some things I really liked about being a contractor, and there's a lot more freedom. And in my county, there is some stability here with not being a contractor, but being a regular employee as well, and benefits. So I think that that's kind of a question for each individual person.
Dr. Trammell, you only contract, right? So is that right?
Yes. Yes, based on that same answer is to be an employee is to be an employee. You have rules and guidelines and things like that. To be a
Mhm.
subcontractor, I can take a contract and I can add 6 to 12 hygienists involved into that contract. And so instead of taking us a whole year to finish, we're finishing it in 2 months, right? But as an employee, I couldn't do that. So it allows the flexibility of, hey, what's the big picture here? What are we trying to accomplish here? Are we wanting one school district a whole year? Or are we wanting 4 school districts in a whole year? And it's based on the plan and the preference of that county and how do you want to move, right? And that's what I do is I sit there and say, how do we want to move forward? What is our goals and how do we want to get there? And what do we need to in order for those steps to be accomplished? You know, do I have 2 months to do it? Do I have 6 months to do it? Do I have 9 months to do it? Yeah, so I would prefer subcontracting. Stability wise, there's enough work to go around, right? So school-based, especially if you're doing it for 6 hours, I mean, what one hygienist can do in 6 to 8 hours, we can probably do it with the subcontract in 2 hours because we can expand faster.
There's some questions in the chat about the other things that you do, Jennifer. Do you do fluoride varnish application? Do you do the care coordination?
I do the care coordination myself as well, although I do have more help now. I have what we call liaisons. Some schools here have liaisons and some don't. Community schools who focus on the whole health of the child all have liaisons. So I act as a mediator with them because a lot of those in community schools are also dual language, and they're all dual language. And my Spanish is okay, but sometimes it's nice when you have a lot of kids to help get providers and to set that up and to make sure it's all done correctly. It's nice to have them available. So a lot of times I will get the information from the nurse. I will have the liaison then follow up. I have the liaison follow up with the family, make sure they get their appointments. And if they have problems, what they'll do is they'll call me back and tell me what the problem is. And then we can focus on that. And then we will all work that problem out together. So I do all the services except for the sealants. And I'm working through getting a sealant clinic here. We just contracted, sent in an RFP to get the clinic set up. So we're just working on that, and that's for the future.
Great. And there's a question for you, Dr. Trammell. Do you offer any more services than cleaning, sealants, and fluoride?
Oh, that's pretty much it. Because what I teach hygienists we are the conduit between the dental home and the school. So we're not there to do all of their treatment, right? Especially if you have providers that are in your local area, because a dental hygienist cannot be the dental home for the actual student, right? And so in order to keep peace is what I call it, I partner with dental offices that are in that school district, that's around that school district. I form relationships. And this is another thing that we want to talk about when we're bringing providers to the table, is provide those relationships with them to become that referring home for those students. Because if I'm in a school and I do all of their cleanings, fluoride and sealants, these are Medi-Cal patients, right? So we already know the reimbursement is low. And now I'm going to take the x-rays. I can't do anything with x-rays. I can't do the fillings, right? I can't extract the tooth. You know, we're not going to do the papotomy. So I'm taking an x-ray. I'm billing Medi-Cal for those x-rays. And then the kid is left there, right? So what I also say is, I do the preventative services, and then I hand off if anything is needed more so, right? Because I need a dental home for this student to be able to go to be a part of. And therefore, the dental office wants to know they have something to bill for, but if I did all the x-rays, an FMX, full mouth set of x-rays, now they go to the dental office, they want to do a full set of x-rays, they can't bill for it because you've already been taken by the hygienist. Now you're forming, tension between the two partners. And that's not something that we want to create up front. So I'll let you guys know on that piece from the LOHP side. So I leave all of those things alone. So therefore they can get there. Now, I am looking at a different program where I'm bringing a dentist into the school because some schools say, hey, the kids aren't going to go, the parents are not going to take them. So what we're trying to do is set up 1 day a week where I do have a dentist that'll come in, his office will come in and set up and actually clean or actually do treatment on the kids that we know the parents have barriers of getting to the dental office. So that is something that we are looking to set up for 24-25.
Okay, great. I think those are most of the questions that we received in the chat. If anyone has other questions for Jennifer and Travis, you can raise your hand or unmute yourself. In the meantime, I'm going to go ahead and launch our evaluation poll, and I'm going to put the evaluation survey link in the chat, and I'm going to just do a little bit more of wrap up here. But again, if you have questions, please feel free to raise your hand or drop them in the chat while we're still on. Okay, so I just wanted to announce that there are going to be a couple of upcoming webinars. The project directors meeting is happening on the 6th, so be on the lookout for a save the date and more information from Cindy at CSUS on that one. And then our COHTAC Next Share and Learn is going to be on June 20th, and it's going to focus on community water fluoridation. So the registration links will be sent out shortly for that one. And then I also want to announce that COHTAC is starting something new called the Score Corner. And this is really a place to group individuals from LOHPs who want to highlight success stories about working with SCORE and to work together to figure out ways to troubleshoot issues that you might be having with SCORE and to participate in peer-to-peer learning. The goal is to put some success stories in the Office of Oral Health Bites quarterly newsletter to highlight your SCORE champions. And if you want to participate, go ahead and email us at oralhealthsupport@ucsf.edu. And Katie Conklin from our team will group you all, we'll have discussion, and that should be an ongoing sort of support tool for you. I think that's all I have. Yeah. So were there any questions that people had for Travis or for Jennifer? Let's see if I can stop sharing. If not, we'll call it a day. And thank you all for joining us today. And thank you, Jennifer and Travis, for taking the time to answer these questions. We really appreciate it.
Thank you.
Thank you.